Good evening. Myself, Dr. Anita Behera. Today we'll discuss postoperative sepsis management. Why postoperative sepsis management is very important without wasting the time? Because sepsis and septic shock are medical emergencies, and we recommended that treatment and resuscitation should begin immediately. Postoperative sepsis management, there are the few guidelines also there. So we'll discuss one by one. First, early identification and prompt action, immediate broad spectrum antibiotic administration, rapid fluid resuscitation with crystalloids, hemodynamic support with vasopressor, source control, corticosteroids, ventilator support, nutritional therapy, anti-aspiration prophylaxis, blood sugar monitoring, DVT prophylaxis, analgesia, blood transfusion, and management of post-sepsis syndrome. Early identification is very important to save the time and save the life. Early identification by assessing the quick sequential organ failure assessment. Remember that the hypotension when systolic blood pressure is less than 100 millimeter of mercury. Altered conscious level, that the GCS level is less than 50. We can see that ABP, A is for the alert, B is for the verbal response to the commands, and P is response to the painful stimulus. Whenever there is a tachypnea, respiration rate is more than 22. If 2 out of 3 criteria is present, then we are calling it the sepsis. Predicted mortality is more than 10%. Organ specific parameter in the screening. The respiratory parameter, PF index, that is partial pressure of arterial oxygenation divided with the fraction of the inspired oxygen ratio. Hematology, platelet count, liver, bilirubin, renal, serum creatinine or urine output, brain, Glasgow Coma scale, cardiovascular system, hypertension, and vasopressor requirements. If a patient comes with signs of a sepsis and there is a probable source, Latin will send all the laboratory investigations like C-reactive proteins, then procalcitonins, blood cultures, and it indicates that the patient is having infection. And as per the definition, if organ dysfunction is there, then it's called as the sepsis. So similarly, this is the screening, how to screen the patient immediately. You can screen by the SARS criteria. Already we discussed that either the SOPA score or Q super score or national early warning score or modified early warning score. So coming to the resuscitation. The resuscitation should start as early as possible. The 1 hour bundle initial resuscitation of the sepsis and septic shock shows that measure the serum lactate. If the lactate level is more than 2 millimole per liter, obtain the blood culture before administering the antibiotic. Administer the broad spectrum antibiotic. For resuscitation with the crystalloids, approximately 30 ml per kg, along with the vasopressor supply, if you are unable to maintain the mean arterial pressure more than 65 millimeter of mercury. Time to start antibiotic. The guidelines are the early administration of appropriate antimicrobials, most effective intervention to reduce the mortality. It must be balanced against the potential harms and administering unnecessary antimicrobials without infection. Antibiotic, we should choose which of the drug of the choice, what should be the dosage, what should be the duration, and what should be the de-escalation. The recommendation says that if a patient coming to you and patient is having shock is present, sepsis is defined or probable, then start the antibiotic immediately within 1 hour of recognition. If the patient's shock is present and sepsis is possible, still administer antimicrobials immediately, ideally within the 1 hour of recognition. If shock is absent, then rapid assessment of infectious versus non-infectious cause of the acute illness and administered antimicrobials within 3 hours if concern for infection persists. Recommendation shows that suppose a patient with a high risk MDR organisms are there, two antimicrobials with gram-negative coverage as empirical therapy is suggested. For patient with a low risk MDR organism, use of 2 gram-negative agents as empirical therapy not suggested. For patient, once causative agent and susceptibility are known, 2 gram-negative agents are not suggested. Recommendation using procalcitonin and clinical evaluation is suggested to decide when to discontinue antimicrobials. Antibiotic stewardship: do not start antibiotic when there is no evidence of infection. Narrow the antibiotics once pathogen identified and sensitivity are established. Antimicrobial durations of 7 to 10 days is adequate for most serious infections. Then coming to the fluid resuscitations, if the patient having the sepsis or septic shock, these are the all medical emergencies, and the treatment and resuscitation should begin immediately. For sepsis-induced hypotension or the septic shock, at least 30 ml per kg IV crystalloids should be given within the first 3 hours of resuscitations, along with dynamic parameters. Recommendation says that for adult with a septic shock on vasopressors, minimum target of mean arterial blood pressure should be 65 millimeter mercury or higher. Previously, the standard parameters were systolic blood pressure, heart rate, central venous pressure, but the dynamic parameters very useful to resuscitate the patient. That is the response to passive leg raise, stroke volume variation, pulse pressure variation, and use of echocardiogram. Passive leg raise test, it's a substitute for the central venous pressure. The blood pressure checked at the baseline, the 45-degree elevation, then just reverse the leg side, and the BP checked within 1 to 5 minutes. If the pulse pressure, that is the systolic blood pressure minus diastolic blood pressure, is more than 9%, it indicates that the fluid responsiveness, that the sensitivity is 79% and specificity is 85%. Then coming to the pulse pressure variations, because of intrathoracic pressure varies during inspiration and expiration. So this is the P max and this is the P minimum. So pulse pressure variation calculates at the pulse pressure maximum, PP max minus PP minimum divided by P max plus P minimum divided by 2. That is the mean pulse pressure into 100. Pulse pressure interpretation, if the high pulse pressure variations are there more than 10 to 15%, that means it's a fluid responsive. If low pulse pressure variations are there, may not be fluid responsive. But factors affecting the pulse pressure variations like the tidal volume, high tidal volume, respiration rate, patient positions, and cardiac functions, it interferes with the pulse pressure interpretations because it changes the intrathoracic pressures during inspiration and expiration, and may not be accurate in the spontaneous breathing patients. Recommendation for fluid resuscitation says that crystalloids are the recommended as first line of a fluid for resuscitations. Balanced crystalloid are more recommended over normal saline. Albumin is suggested in patient who receives large volume of crystalloids. Vasoactive agents, it says that during resuscitation of the fluid, since most of the patients have the multi-organ dysfunctions, so simultaneously resuscitation of the fluid along with vasoactive agents should start simultaneously. Noradrenaline as the first choice, intent of raising mean arterial pressure to the target value. If shock is not resolving quickly, then further hemodynamic assessment such as assessing cardiac functions is mandatory. The recommendation says that use of norepinephrine or noradrenaline as the first line of vasopressor for the patient's septic shock on vasopressor. Target of mean arterial pressure is to maintain 65 millimeter of mercury or above. Consider invasive monitoring of the arterial blood pressure. If central access is not available, suppose you receive a patient, there is no central line. So immediately consider initiating the vasopressors peripherally. If MAP is inadequate, despite of a low to moderate dose of norepinephrine, consider adding vasopressors. If cardiac dysfunction with persistent hypoperfusion is present, despite adequate volume status and blood pressure, then you may think or consider adding dobutamine or switching to epinephrine. Corticosteroids, the role of corticosteroids, it comes in another 24-hour bundle, particularly for the patients with the refractory septic shock. If you are unable to maintain the blood pressure level along with the fluid resuscitations and with a vasopressors, then we can start the corticosteroids, and preferably the hydrocortisone is the preferred, and the dose is 200 milligram per the day. You can give either continuous infusion or 50 milligram every 6 hours. The side effects like hyperglycemia, hypernatremia should be optional. Source control is very, very important. Appropriate source control is the key principle in the management of sepsis and septic shock. The source control should occur immediately after resuscitations, preferably within the 6 to 12 hours of identifications. It may include the drainage of the abscess, debridement of necrotic tissue, removal of the potential infected devices. A least invasive option that effectively achieves source control should be pursued. Foci for infection readily amenable to the source control includes that intra-abdominal abscess, gastrointestinal perforations, ischemic bowel or valvulus, cholangitis, cholecystitis, pyelonephritis associated with obstruction or abscess, necrotizing infections, then deep space infection like empyema, septic arthritis, or implant device infections. So we should rapidly identify, and it's the multidisciplinary approach where you need the help of the surgeon, anesthetist, and critical care intensivist. Intravascular devices, the recommendation says that intravascular devices suspected to be the source should be removed after initial resuscitations and another site is established. Some implanted, if removal is not practical, then you may be treated effectively with a prolonged antimicrobial therapy. Then if the patient on the ventilator and the patient having the ARDS, that is acute respiratory distress syndrome, then we should go for the protective lung strategy or to reduce the ventilator induced lung injury. That is for the low tidal volume air setting. Prone position ventilations, in the low tidal volume 4 to 6 ml per kg ideal body weight. Prone position 12 to 16 hours per day. Conservative fluid management should be there, and driving pressure, that is the plateau pressure minus PIP, it should be less than 15 centimeter of water. Mechanical power reduction should be there. Inhaled pulmonary vasodilatations to decrease the pulmonary arterial pressures. Neuromuscular blocking and sedations considered. Some studies say that the early start of the glucocorticoids, it may help to reduce the inflammation and it helps in decreasing the ventilator-associated lung injury. And consider the, if refractory hypoxemia is there, then you may consider for the venovenous ECMO. Then blood transfusion. The recent guidelines says that a restrictive approach of a blood transfusion should be there to avoid the overloading and other complications. If hemoglobin is less than 7 grams per deciliter, then should transfuse the blood. Target level is 7 to 9 grams per deciliter. Suppose post-operative patient, even if you have the hemoglobin more than 9, but with the patient is active bleeding, severe hypoxemia, or ischemic heart disease patient, or plan for a re-exploration, then can transfuse the blood. Platelet transfusion, the recent guidelines says that stable non-bleeding patient less than 10,000, stable non-bleeding and body temperature more than 100.4 degree Fahrenheit, less than 20,000. Surgery with active bleeding, less than 50 usually. Ocular surgery and neurosurgery, but no active bleeding, less than 1 lakh. Major surgery or invasive procedures, no active bleeding, less than 50,000. Then coming to the nutrition support is very, very important for the early recovery of the patients. So recommendation says that early enteral nutritional support should start as early as possible. Moderate protein intake 1.2 to 2 gram per kg per the day. Calorie restrictions in acute phase 20 kilocalorie per kg per day, and the recovered phase it can be increased. And some micronutrient corrections should be there. When enteral nutrition is not possible, then total parenteral nutrition should start as early as possible. Anti-aspiration prophylaxis to prevent the ventilator associated pneumonia, VAAA, patient positioning, proper oral hygienics, medications like proton pump inhibitors, prokinetics, ulcer prophylaxis like Shukrel should supplement to the patients. Blood glucose monitoring is very, very important. You should avoid hypoglycemia as well as hyperglycemia. Target blood glucose level is 140 to 180 milligram per deciliter. If more than 180 milligram per deciliter, can start the insulin infusion. Avoid metformin because metformin causes non-hypoxic lactic acidosis, which further increases the mortality of the patients in the case of sepsis. New regimen says that the blood glucose level can manage to less than 150 milligram per deciliter. DVT prophylaxis is very, very important also. Recommendation says that early mobilization within 72 hours of ICU administrations, physiotherapy, change in the position of the patients, and drugs like low molecular heparins can be given if there is no contraindication. If contraindication is there, then you can go for the unfractionated heparin or mechanical like the compression stocking. Analgesia, multimodal analgesia should be started, titrated according to the organ functions for the early recovery of the patients. Antifungal therapy, the risk of the fungal infections are the new patient is having neutropenia, immunosuppression, longer ICU length of stay, central venous catheter or other IV device present, total parenteral nutrition, IV drug user, broad spectrum antibiotics are there, prior surgery is there, particularly hollow viscous perforation surgery is there. So for patient at a high risk of fungal infection, empirical antifungal is suggested. So coming to the conclusion, this is the chain of sepsis resuscitations where immediately detection of the sepsis by the source organ failure and the lactate that is within 1 hour, and source control like sending the blood cultures, antibiotics should start with less than 1 hour, and the drainage should be less than 12 hours after resuscitation. Then oxygen and crystalloids 30 ml per kg if the mean arterial pressure is less than 65 millimeter of mercury or shock index is more than 1. Monitoring mean arterial pressure should be more than 65 millimeter mercury, normovolumia, urine output, lactate clearance, and saturations. It should be more than 90%. And addition of the vasopressors like norepinephrine and ICU requirement evaluations if required. The time saves the life. Management of a post-sepsis syndrome. This consists of immunological, cardiovascular, and cognitive deficit that persists long after hospital discharge. So the patient requires good nutrition therapy, good psychological therapy, good physical physiotherapy. So every care should support to the patient for early recovery and join to the flow of the society. So take home message that whenever a diagnosis, a sepsis case or septic shock patient, without wasting the time, early diagnosis, simultaneous administration of antibiotic along with a blood culture and resuscitations with crystallars along with vasopressors should start immediate along with the source control. There is no gold standard diagnosis to treat this patient. Ideology is that clinical evaluations and clinical ability should be persistent. Thank you.